Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Stand Medical Lecture on Notes. So let's continue the topic of diabetic kidney disease. So let's begin with the name of Almighty. So how do you differentiate between diabetic kidney disease or diabetic kidney disease or non-diabetic renal disease or mixed lesions, both DKD or NDRD? Differentiating background DKD from pure NDRD or mixed DKD plus NDRD regions is a critical clinical decision point that directly guides the choice between standard cardiorenal supportive therapy and targeted immunosuppression. So to differentiate, we need history, we need systemic microvascular findings, that is about fundoscopy, urinary microscopic sediment, that is about urinary microscopy, biopsy in some cases, and some advanced clinical discriminants. So main thing, history, you can take it as history, and this is fundoscopy, this is urine microscopy, this is biopsy. Okay, so in diabetic kidney disease, duration will be long, more than 10 years or at least more than 5 years. Gradual predictable onset of microalbuminuria progressing to overt proteinuria. Okay, in NDRD it is short duration, less than 5 years, and this abrupt rapid development of proteinuria or renal decline, nothing but EGFR. In mixed lesions, there will be long history of diabetes mellitus, previously stable followed by a sudden unexplained step up in proteinuria or GFR loss. Now in fundoscopy, what we will see, so you will have diabetic retinopathy in case of DKD. In NDRD there will be no evidence of diabetic retinopathy, and in case of mixed lesions there will be a background diabetic retinopathy present but does not fully explain the severe renal presentation. So there will be discordance between retinopathy and the severe renal decline, that is seen in mixed lesions. Very important point. Okay, that is fundoscopy. Urinary microscopy is typically bland. There will be acellular sediment with hyaline or occasional granular casts, whereas in NDRD there will be active sediment with hematuria or dysmorphic RBCs or RBC casts or cellular cast also. Here it will be variable. A previously bland sediment becomes active with a superimposed secondary glomerulonephritis. So in biopsy, DKD we will have Kimmelston-Wilson nodules or noduloglomerulosclerosis. Okay, and most common pathological diagnosis is diffuse glomerulosclerosis, mesangial expansion, basement membrane thickening, and this is the pathological hallmark of this DKD: diffuse glomerulosclerosis, basement membrane thickening, mesangial expansion. And the most common cause of this NDRD is IgA nephropathy, which is most common. Then comes the membranous nephropathy and mesangoproliferative GN, that is nothing but MPGN. Okay, remember the most common, that is IgA nephropathy. Mixed lesions, concomitant diabetic glomerulosclerosis coexisting with secondary active lesions, most commonly IgA nephropathy. So remember, IgA nephropathy most common cause of NDRD. Some advanced clinical discriminants. So in DKD, stepwise discriminant models show high diabetic retinopathy, elevated fasting blood glucose, and high total cholesterol levels are highly indicative of pure DKD. Three things. First, there will be, in that three things, two are very important: presence of diabetic retinopathy and presence of total high cholesterol levels, and along with that elevated fasting blood sugar levels. So these three will help us to discriminate. In NDRD, there will be stepwise discriminant models show lower EGFR, vitamin B12 deficiency, this is very important, lower blood glucose are more indicative of general CKD or NDRD. Okay, NDRD, low blood glucose, very important one. In mixed lesions, a combination of chronic diabetic metabolic profiles along with acute markers of systemic or immunological activity. So you can have either of the three. So DKD should be differentiated from NDRD or from NDRD plus TKD. So look for red flags already discussed: short DM duration less than 5 years, no diabetic retinopathy, and presence of active urinary sediment in microscopy, rapid decline in terms of EGFR or proteinuria. So these are the red flags to identify NDRD early, because many NDRD causes are treatable and potentially reversible. That's about the differential diagnosis, how to differentiate. Now, how do you approach investigative approach? You can say that investigations. So first, you will have in a patient of diabetes mellitus initial annual screening of either UPCR, urinary protein creatinine ratio, or UACR, urinary albumin creatinine ratio. Okay, so in type 1 diabetes mellitus, it is recommended that screening should start 5 years after the diagnosis, whereas in type 2 diabetes mellitus, it should start immediately. How? By EGFR and urinary albumin creatinine ratio, or you can also take it as UPCR. Okay, so initial annual screening, and you will use spot UACR or UPCR. Then while taking while taking the sample for EGFR or UACR, then remember some conditions where these are found. Confounders, those are called. Exclude transient non-pathological confounders, like if the patient has UTI, active UTI, or if the patient has marked acute hyperglycemia more than 270 milligram per deciliter, patient has congestive heart failure, intense physical exercise within preceding 24 hours, high fever, acute febrile illness, severe uncontrolled hypertension, important, and menstruation. So in these cases, you should not take the EGFR and USR values, because they will be raised in these conditions. So they will be raised because of these conditions, and it will be misinterpreted as diabetic kidney disease. So you should exclude these conditions: UTI, menstruation, marked hyperglycemia, intense physical exercise, congestive heart failure, fever, uncontrolled hypertension. So if these conditions are not there, at that time you should take these samples. So you have collected the samples. Now confirm the persistent albuminuria. How do you confirm? Take 2 samples 3 months apart. 3 months apart. That is one. Then in some cases, integrate serum cystatin C. Why? Integrate serum cystatin C, that means while calculating EGFR, there are formulas. So there is the famous formula is CKD-EPI. CKD-EPI, this is the most recommended one, and second recommended one is CKD-MDRD. So in these formulas, you should integrate this serum cystatin C, already available on apps, medical apps. Okay, so where we should integrate this serum cystatin C, where the creatinine based GFR estimation may be inaccurate, like if the patient is in extreme sub-body hepatitis, too obese or too thin, severe liver disease, muscle wasting disorders, or acute illness. So in these conditions, what will be there? So either the creatinine will be very low, or the creatinine will be very much raised. So that's why, because there is no muscle mass only. Okay, or liver is not clearing creatinine. Okay, or there is muscle wasting disorder or fever, because of rigors, there will be increased creatinine levels. So in these conditions, liver conditions, in the extremes of body hepatitis, acute illness, and muscle wasting disorders, one should integrate serum cystatin C. So this equation should be combined, EGFR CR cystatin C equation, to improve the GFR accuracy for clinical decision making and precise drug dosing. Okay, so any condition which which creates a rhabdomyolytic picture, rhabdomyolysis like picture, or if the patient has doesn't have any muscle mass, or and he has so much of adipose tissue. So in these type of conditions, this cystatin C should be integrated. Okay, now you have taken the sample of for EGFR and USR, and you are excluded the transient confounding factors like acute illness, extreme hypoglycemia, uncontrolled hypertension, UTI, menstruation, and heart failure, all these things, and you have taken the sample, and you have confirmed the persistent proteinuria also. Now what you do, you perform a comprehensive dilated fundus examination. Now why you should perform, and it should be performed by an experienced ophthalmologist, remember. Okay, presence of retinopathy supports the clinical diagnosis of background DKD, whereas its absence should prompt consideration of alternative etiologies. So there should be diabetic retinopathy in a patient with DKD. If there is no diabetic retinopathy, meaning proliferative diabetic retinopathy or non-proliferative diabetic retinopathy, then you should think of some other etiologies. Okay, so this is a very important point. Now after that, you calculate the kidney failure risk equation. So it will give some percentage to you. So for patients of stages from G3 to G5, calculate the 2-year and 5-year KFRE risk scores using the age, sex, EGFR and USAR. A 5-year KFRE score of more than 5% or 2-year KFRE score of more than 10% serves as an objective evidence-based referral point for interprofessional nephrology care. So if after calculating KFRE, how do you calculate KFRE? Again, you have some medical apps in your mobiles nowadays. So there or online you can go and you calculate by using this KFRE. So kidney failure risk equation. So if it is more than 5% in 5 years, 5 years score, 2 years score more than 10%, then you should refer to a nephrologist. That will give a clue when to refer to a patient. Okay, that is one thing. Okay, and the other thing is we should have in mind that we may need an urgent referral to a nephrologist, and biopsy may be needed in some cases. So when should that be needed? So one thing is referral depending upon the kidney failure risk equation. One thing is depending upon some urgent referral is required. So if clinical red flags for NDRD are present, or you have a mixed picture of DKD or NDRD, then you should refer the patient for biopsy, because the patient may be having some CTDs, connective tissue disorder, or some IgA nephropathy, which get resolved by this immunosuppressive drugs. So that's why we should refer these kind of patients. So just to summarize, so what we are doing, the investigative approach, we are calculating EGFR, okay, and UACR, excluding the confounding situations, meaning the situations which raise this temporarily, confounding factors. Okay, so we have collected in case of DM1 after 5 years, more than 5 years, in case of DM2 at starting point only, at onset only. So we have done this one. And second thing what we are doing is, in some patients we may integrate cystatin C. So we have taken EGFR USR, then we will take 2 years. So we are taking these samples, we should take 2 samples 3 months apart. That is the one thing. Second thing is, in some patient we should integrate serum cystatin C. Third thing is, you should confirm by diabetic retinopathy fundoscopy. If diabetic retinopathy is not there, then think of alternative diagnosis. Fourth, we should calculate the kidney failure risk equation, and we should refer whenever the 5-year score is more than 5% or 2 years KFRE score is more than 10%. And so in some cases, urgent situations, biopsy related, at that time also we should refer the patient whenever we are suspecting NDRD. Key takeaway is screen, confirm, evaluate, risk stratified by KFRE, okay, and refer when needed to ensure accurate diagnosis and optimal patient outcomes. So that's a step-by-step approach of investigations. Okay, now coming to the management of diabetic kidney disease, very important. Okay, so management, I will just give a overview. So this has 5 things. One is integrating lifestyle interventions. Second is first line pharmacotherapy foundation. Third is targeted additions for residual risk. Fourth is standardized blood pressure targets. Fifth is refractory hypertension management. So these in 5 things you can divide this management. Coming to the, so you say this as layered cardiorenal metabolic strategy. Managing DKD requires an integrated cardiorenal metabolic approach combining systemic cardiovascular risk modification with targeted renal protective pharmacotherapies. In that, first one is lifestyle interventions. So dietary sodium intake should be restricted to less than 2 gram per day, or you can take 5 gram of salt per day to optimize BP control and reduce proteinuria. Or you can simply say to the patient, you should not take added salt diet. No added salt diet the patient should take. Okay, that is one thing. Dietary protein. So maintain 0.8 gram per kg body weight per day. Avoid stricter protein restriction because there is a risk of protein energy wasting. So patients should be informed they should take a good, not high, we can say a good protein diet. Okay, and maintain physical activity. So they should avoid sodium, they should take a good protein, and they should have physical activity, moderate to intensity exercise for at least 150 minutes per week, tailored to individual capacity and fall risk. And fourth one is smoking cessation. Encourage complete tobacco cessation to reduce cardiovascular events and slow renal decline. Okay, smoking will exacerbate the renal decline and cardiovascular happening of cardiovascular events. Smoking will exacerbate 4 things: sodium, protein, lifestyle, and smoking. Coming to first line therapy now. Number 1, start Rais in blockade by starting giving AC inhibitors or ARBs. So preferred drugs in AC inhibitors are lisinopril or enalapril. ARBs are losartan and candesartan, remember. Okay, you can others also tell me sartan, olmesartan, those things also. But one thing to remember is they should be given at maximum tolerated dose for all patients with hypertension with albuminuria. This is the important point. The AC inhibitor or the ARBs which you are giving, they should be given at a maximum tolerated dose. Okay. In patient with hypertension with albuminuria, all patients with hypertension with albuminuria. But you should not combine AC inhibitor along with ARB. You should not combine. Okay. So that is the one thing. Ras blockade. Second thing is SGLT2 inhibitors. So what these two will do? These two will reduce the intraglomerular hypertension. So glomerulus is hypertension in the glomerulus. We have discussed in the pathophysiology. So we should initiate SGLT2. The preferred one is canagliflozin, dapagliflozin, empagliflozin for all patients with type 2 diabetes mellitus having CKD, and EGFR, the condition is EGFR should be more than 20. It should be. Suppose you have started SGLT2 inhibitors initially only, meaning when the EGFR is between 45 to 60, and now the patient is having EGFR less than 20, then you should not stop SGLT2 inhibitors. You should continue the SGLT2 inhibitors whenever the patient tolerates. But if you are starting the SGLT2 inhibitors, then if the patient has less than 20, you should not start, and more than 20 you should start. That is how you should start the SGLT2 inhibitors. Now third thing is statin therapy. Why? As we have discussed that CKD raises the risk of cardiovascular disease and cardiovascular events. So to prevent that, we are giving moderate to high intensity statin, atorva or rosuvastatin for all DKD patients to target. So the target should be LDL cholesterol less than 77 milligram, or take it as less than 80 milligram per deciliter. And if the patient has symptomatic cardiovascular disease, then the target is again stricter, that is less than 70 milligram per deciliter, less than 80, less than 70. So you should use statins. Okay. The one thing is metformin. Why metformin? So the normal maximum dose of metformin is 2 gram in patients who don't have kidney disease, but this maximum dose will become 1 gram in patients with diabetic kidney disease. And one thing is you can give till the stage of G3B, meaning when the GFR is more than 30 only. If the GFR goes less than 30, then you should stop metformin. That is important point. Otherwise the patient will have a very high risk of Mala, which is already discussed, metformin associated lactic acidosis. Okay, metformin associated lactic acidosis. Patient will have a severe refractory shock. That is the presentation, no? Severe refractory shock, and then CNS symptoms. So these four things are important. RAS, and when should, again, RAS also, if the patient, you should start only when the eGFR is more than 30 RAS. If it goes less than 30, you should not start ACE inhibitor or reverse, because it will deteriorate the function of kidneys. That is one thing. Now, some additional drugs also you can start. What are those additional drugs? One is non-steroidal MRA. So one thing is steroidal MRA, that is nothing but spironolactone. Other thing is non-steroidal MRA, that is finerenone. So remember here it is NSMRA, meaning non-steroidal MRA, not spironolactone. Okay. So that is finerenone. Should be added in type 2 diabetes mellitus. The condition is eGFR should be more than 25 and potassium should be in the normal range, and patient is having persistent albuminuria, meaning more than 30 milligram per gram or more than 150 milligram per gram. This is in terms of UPCR and this is in terms of USCR. Okay, 150 to 500. So if despite maximum tolerated RAS inhibitor, if you are giving AC inhibitor or ARBs at maximum tolerated dose and still the patient is having proteinuria in the form of albumin, USCR or UPCR more than the microalbuminuria range, then you can start finerenone in these patients. Okay, that is additive therapy. Second thing is GLP-1 receptor agonist. That's about proteinuria not controlled in spite of high maximum tolerated RAS inhibitor, proteinuria. So this is I can say I will write like this. So this is for residual proteinuria. Okay, GLP-1 receptor agonist, this is for residual high glucose. For type 2 diabetes mellitus patients not at glycemic target despite lifestyle, metformin, SGLT2 inhibitors, prioritize long-acting GLP-1 receptor agonist like semaglutide over insulin. So what do you think? So patient is not having target HbA1c FBS is not achieved by oral drugs alone. So we will directly start insulin. But the guidelines say if prioritize this GLP-1 agonist over insulin. So even after giving GLP-1 agonist, if the patient is having not achieving glycemic target, then you can give insulin. Okay, because insulin causes weight gain actually, and weight gain is not good for these patients. Okay, and also these patients are at high risk of hypoglycemia because insulin is not degraded by the kidney. Okay, so this comes from a study, a trial known as flow trial, where subcutaneous semaglutide 1 mg once weekly given reduces the risk in major 24% relative risk in major kidney disease events, kidney failure or sustained what are those kidney disease events, like kidney failure or sustained more than 50% GFR decline, renal or cardiovascular death, and slowed, along with that it slowed annual loss of kidney function by 1.16 ml, 1.16 eGFR, you can take 1.2. So this is very important point, meaning it is suppressing the kidney events as well as it is suppressing the progression of your DKD. So that's why semaglutide 1 mg, remember the dose, titrated slowly up to 1 mg. You should prioritize over insulin. Okay, because of this thing. Now residual proteinuria, how to tackle, we have discussed. Residual glycemic, how to tackle, we have discussed. Now there will be some standardized blood pressure targets. Like standard target is SBP should be less than 120. This is the standard target. But in some patients like elderly or comorbidities, the target should be individualized. Okay, either less than 120 or not possible to less than 140 in patients with advanced age, high frailty, okay, falls and fractures, limited life expectancy, or symptomatic postural hypotension. So in these patients, in elderly patients of 50 to 60 years of age or having comorbidities or postural hypertension, you can relax the target to less than 140 SBP or less than 130. Standard is less than 120. Now we have residual proteinuria, how to tackle, we have discussed. Residual increased glucose, how to tackle, we have discussed. Now residual hypertension, how you will tackle, even after giving all AC inhibitors things. So here is the thing, if BP is uncontrolled on AC inhibitor, ARB, SGLT2 inhibitors and MSA, in these three things first you should give. Okay, all these three things will decrease the BP. First, maximum dose of this one, and you should start this also, and then this is an add-on therapy, for proteinuria. Okay, if this is not controlled, the next choice is dihydropyridine calcium channel blocker like amlodipine. Nowadays cilnidipine has come, cilnidipine, so this is preferred over amlodipine because of its profile, anti-proteinuria effect, as well as less side effects, okay, and good cardiovascular effects also. Okay, you should add a calcium channel blocker. Okay, still resistant, then you can add there thiazide like diuretic like chlorothalidone or indapamide. Indapamide is the safest, chlorothalidone next is safest is chlorothalidone. Okay, still not, if the patient has edema, then you can choose over a loop diuretic like torsemide or furosemide or torsemide if the patient has edema. That's how you tackle the resistant hypertension. Okay, so overall goal over here is slow the CKD progression, reduce the cardiovascular disease, improve the quality of life, prevent kidney failure. Early initiation, regular monitoring and combination therapy are key to better cardiorenal outcomes in DKD. Now, while giving this SGLT2 inhibitors and RAS inhibitors, you should have some points to be kept in mind. So when you start SGLT2 inhibitor, there is a natural EGFR dip, meaning fall. So what happens after starting or increasing an SGLT2 inhibitor, there is a transient decline in GFR less than 30% in the first 2 to 4 weeks, meaning 15 days to 1 month. Okay, it is a functional hemodynamic change, not a structural damage. It reflects reduced intraglomerular pressure due to restoration of tubuloglomerular feedback. So what to do? So if the fall is less than 30%, don't touch the SGLT2 inhibitors. If the fall is more than 30%, you should evaluate and consider stopping the SGLT2 inhibitors. Okay, and you should stop temporarily SGLT2 inhibitors. This is all Sadman's regimen, you already remember. Okay, in volume depletion state, hypotension state, nephropathy, because it raises the risk of DKA as well as MALA, both it raises the risk. Okay, similarly for RAS inhibitors, you should monitor creatinine and potassium changes. So after starting, so these things, AC inhibitor, ARB, NS, MRE, there is a natural dip in creatinine and raise in potassium. Now if the dip is more than 30% of baseline EGFR after within 4 weeks of starting or more than, then you should stop this one. Okay, if it is less than 30%, then you should continue. Now if hyperkalemia develops, use potassium lowering strategies. Don't stop RAS inhibitor directly, but instead what you do is you implement strategies to lower the potassium, like dietary counseling, have low potassium diet, or you can do you give diuretics, or if the patient is already on diuretics, you can titrate the diuretics. Okay, they itself cause potassium loss through the urine, both the thiazide type of diuretics and loop diuretics, or you can use potassium binders. So usually these patients have calcium deficiency. You can use nowadays they are available as like calcium lanthanate like this in this form, or calcium carbonate itself binds potassium in the GI. So these things you can use to reduce the, but even after these also, if the potassium is not under control, not in the range, then you can think of reducing the dose of RAS inhibitor. If still after 15 days you measure still the potassium is high, you stop the RAS inhibitor, okay, and start calcium channel blockers. That's how you take the action. Okay. Now some common clinical pitfalls to avoid. Never ever combine AC inhibitor and ARB or aliskiren. What is aliskiren? Aliskiren is nothing but it is a direct renin inhibitor. Renin inhibitor. So this is also a BP lowering drug actually. So never ever combine these three, either of these three. Okay. Otherwise the patient will end up with severe hyperkalemia, hypotension and AKI. Do not combine. The second thing is always have a low inertia for starting SGLT2 inhibitors in patients with CKD. Don't start and don't delay the starting of this SGLT2 inhibitors. Start early in the course. Okay, and always remember metformin dosage. Maximum dosage will reduce from 2 gram to 1 gram in patients DKD, and whenever the GFR falls less than 30, you should stop the drug. Okay. NSAIDs, you should inform the patients not to take NSAIDs like ibuprofen or naproxen. Okay. Patients must be actively counseled to avoid NSAIDs. Combined with ACE inhibitors, ARBs, NSAID induce afferent arteriole constriction and can precipitate severe acute AKI. So what NSAIDs will do, if this is the glomerulus and this is the afferent arteriole and this is the efferent arteriole, so there are prostaglandins here also. Main function of prostaglandins is to dilate the arteriole, but if you give NSAID, prostaglandin production will be inhibited, and because of that there will be arteriolar constriction, and again there will be increased glomerular hypertension. That's why NSAID should not be given in patients with DKD. The last thing is we should always remember the sick day rules, SAD-1 regimen. If you don't give this, patient will have a high risk of MALA and diabetic ketoacidosis. Okay, so this is the common pitfalls to avoid. I think this is enough for today. We will continue in the next video. Thank you.